I'm very honored to be here and to give you an overview. I was asked to do this about advancements in anti-aging medicine. That means advancements in preventive, regenerative, and anti-aging medicine. That's what we found to be under the roof of anti-aging medicine. This is not a real picture, okay? But this is something probably where you can see how the changes might be during the age, especially when people are in this job to do a high-stress job every day. The question is, when we see these pictures, what is behind this? What is behind this aging process? Everybody wants to become old, but nobody wants to be old. So how does it work? We know that and I like this point of aging, is a summary term for a set of processes which contribute to age-related decline in performance and productivity and health. Aging is, as we saw in the previous speaker wrote, in all levels of our body. It starts from the organs to the tissues to the cell and molecular biology. And we have the function decline in the whole body during our age, and this decline of function is what we see. Patients normally, and as we are here among us, we would even mostly go when they have the first signs of deficiencies, but the prevention should start much more earlier. And that's what we heard in our previous lecture. That is a long way to a disease. And the earlier we start, and especially in the mother's womb, I will show you that one reason for this is to go into the mother's womb. The earlier we start, the earlier we can break this way to, let's see here as an example, Alzheimer's disease. See how many years are between this. And what we do is, with the patient comes the first time when he or his family senses that there's something wrong with this patient. What is advanced anti-aging medicine? In the previous years, the molecular research and biotechnology developed with high speed, and every day more and more, and it's huge what we gain in knowledge and what we gain in daily publications, daily papers which are coming out about aging and anti-aging and preventive medicine. If you reconsider the time in the 90s when it started, the word anti-aging, nobody talked about this. They said, oh, what a bad word. But at the end of the day, it is the truth that we have to do something against the worst side of the aging. Not against the philosophy of aging, to be older. This is normal. And this is nice, because to be older is wise. But we have to go into this field very early to prevent. So anti-aging medicine is a clinical specialty founded on the application of advanced scientific and medical technologies for the early detection and prevention, treatment, and reversal of age processes. And one of the most important things is the genetics of aging. To see what is behind why some people are going to be 100 and 110 and more centenarians or super centenarians, or why some people are dying earlier, very fast accelerated in aging. And for this we have one advanced diagnostic, which is the genetic polymorphism diagnostic, to find out what happens in the genes. What is the prescription of myself when I was born? What is the book, the recipe, and how can I change the recipe? This is the point. But if we don't know what is the recipe, we don't even know how to go into this field. We just try. We just try. Measuring, as we heard, some of this laboratory testing is very important, but what will you do? If I ate yesterday, I ate very good. I had a lot of cake, and next morning I go fasting for sugar. My sugar is higher. My fasting blood sugar is higher. So what is behind this? Behind this is the pure knowledge of a genetic recipe. And the DNA research is done, and as well here, we see a lot of studies and papers coming out. Our DNA differs by only 0.1%. And this 0.1%, otherwise we're all the same in the genes. This makes a difference. The 0.1% difference translates into 3 million separate spelling differences in the genome of 3 billion bases. And one very important thing is, give you an example, pharmacogenomics. We have a drug. We take a drug. The question is, what does the drug on the gene? What is our genetic supply for this drug? What do we have to get rid of this drug after a special point of time? We have to metabolize this. So everybody of us probably has a different approach and has different genes. And for example, if I take diazepam, I have faster metabolize than one of you. So there's a different, but how do we know? When we are dead or when we have side effects and we are landing in the hospital? No, that should not be. We should know it before. The genomic testing is so important that even in one of the major reasons of aging, the inflammation, we can look who has a higher risk for inflammation and who has not a high risk. Claudio Francesco called this way inflammaging, because it's inflammation and aging, and inflammation is a basic of aging. So let's see, the polymorphism works on drug and hormone metabolism, drug and hormone transport. We can see the hormone receptor sensitivity, or the drug receptors. We can see if there's a responder to a drug or to a nutrition or to a diet or to an exercise or to a hormone or not. We can see if there's an adverse drug reaction, and we can see risk, disease, susceptibility. This is important, and so we have a lot of polymorphism points where we can look. If your patient comes and says, oh, my mother has osteoporosis, so you go into, especially this field, and look for the genes of osteoporosis, if this polymorphism is inherited. This is an example, for example, disease prediction, disease acute myocardial infarction, Alzheimer's disease. These are the genes. So if there's a mutation, a polymorphism, then there's a higher risk or reduced risk. This is what we can see. Another important thing is the proteome or metabolome. The urine testing, let's say, of the proteins in a prostate cancer or benign prostate hyperplasia or in a normal prostate is completely different, because a hyperplasia and prostate cancer, they produce early, very early, much more early than PSA is measurable, some proteins where you can say there's a high risk of prostate cancer and we have to go deeper. You see, this is a protein distribution, and this is one of the control, and this is prostate cancer. So there is a huge possibility, and even renal cancer as well. There's a great possibility to go into this new field of molecular genetics or proteomics. Another point is, if you have the genes, that doesn't mean you get the disease, because there's something we call epigenetic, and my previous speaker spoke about this. In the mother's womb is the thing which is called the code of the gene, which happens if you will develop the disease or not. Let's say your baby in the womb has a diabetes risk, polymorphism, everything for PPR gamma and everything, insulin metabolism. What happens when this mother has a lifestyle clear, without sugar, clear controlled? This baby probably has a chance not to develop diabetes. But if the mother has a lifestyle because her genes are the same and her genes are hungry for sugars and craving for carbs, and she follows this bad habit, then the baby starts to be a diabetic patient in later years. And it's more harder to get in this than in these early years. The hormone was the same. So epigenetic is at least what is coming out of the recipe. It's a recipe, both had the same recipe and a different epigenetic. Now we come to a point which is very fascinating, is the telomeres. The telomeres are the caps at the end of the chromosomes, and we know that the telomere shortening is associated with the aging process. And we know that there are some diseases like this Guilford-Hutchinson child, which looks like 80 here, and is about 11. So these diseases are correlated with shorter telomeres. And when we have stress, our telomeres shorten faster. Low stress, length of the telomeres, high stress. So there's a lot of things what we have to do. So how can we find something? Low vitamin D has shorter telomeres. We have the possibility, developed in Spain by this famous Dr. Maria Blasco, that we can measure the telomere length from a saliva. And measuring your telomere length, you can say, this is your real age, and now you have something to do. So probably you say, what will we do? We can do something. We can extend, again, the telomere length. For example, with something which was developed by Geron in US, TA65, or otherwise, stress reduction, vitamin C, and much more. Everybody knows this, but nobody really knows what are stem cells. Actually, if you are honest with yourself, the word stem cell goes around the world like a spirit. But what is stem cell? Stem cell is a difficult word because it comes from a cell, actually, which is embryonic. Embryonic cells are the real stem cells. Then we have stem cells, which we call adult stem cells. This is important to know because stem cells have the remarkable potential to develop into many different cells. They serve like a sort of repair system. And when a stem cell divides, it divides normally in a way that a part of this is a real new source as well for the next part. Another part is differentiation to the organ cells. Two different cell types here. You see that embryonic stem cells and adult stem cells. And what we're using today are adult stem cells. Mostly the best at the end are two groups, hematopoietic cells and mesenchymal stem cells. Both from the bone marrow or mesenchymal stem cells come from the skin or from the fat tissue. So, and this is very important to know, if you use stem cells even for, let's say, for the way of aesthetic reasons, you have to differentiate them, to measure them, to see these are real stem cells. It does not work that you put some fat out and then you inject it again and say these are stem cells. There are probably stem cells in between, but nobody knows. And I pay $10,000 for a regimen like this. I want to know, do you put stem cells into, and how many did you give me? I don't want just the fat and just boom, So this is an important point. Therefore, researchers in Harvard and Germany, they found together that there's a novelty cell group in the skin These skin cells are called ABCB5 cells, and called after a transporter of the mitochondria. So these ABCB5 cells, it is a marker. So these marker cells, they have pluripotency. They are at least mesenchymal cells, but they are not induced cells, not iPS cells, and they are not embryonic, but they have the same behavior like embryonic. Why is it important that they are not embryonic? Because embryonic cells are, from the ethic point, a problem, and they are high risk for cancer. And iPS cells are high risk for cancer. So what we have at the end of the day with these cells, we have a cell group we can use in many diseases worldwide. Heart disease, you see, coronary heart disease. In coronary heart disease, you have 2 points to, on one point you have to repair the vessel, on the other point you have to repair the muscle, because this muscle is thin and extended, and this is the heart failure, which is the result of a myocardial heart infarction. So what we have to do, cells regenerate both. Hematopoietic cells are mostly used for the vessel, and the mesenchymal cells, ABCB5 cells, for the, as they have pluripotencies for these vessels and for the muscle. And here you see leg ischemia. This is from Therapeutic in Bangalore. You see before and after, and you see after a short time, about 2 months, you see the new vessels coming in only by injection into the femoral artery. You see the food here, that's a friend of mine from Chile, from Buenos Aires. You see before and after, it's coming up very fast that you can save these patients. Spinal injury, you have a chance, very big chance, to go into spinal injury. This guy can walk with calipers and later can walk as well without calipers. The bladder movement is the first, and this is important in these people who have a spinal injury, when they can control their bladder. This is like, you know, a miracle for them. Diabetes mellitus, the Excel Center here published this data about diabetes mellitus, type 1. Type 2 is difficult, because type 2 is a peripheral problem of insulin resistance. But here as well, this is from Thymus in Germany. You see that they go into the pancreas and inject the stem cells directly to this point. Even you can use them for beauty. This is Roland Ney. Roland Ney is a friend of mine. He works with the Thymus cells, and you see he injects them, and after a short time it's coming up, and the second and third treatment improves even more. And for this treatment, even the skin biopsy here behind the ear is enough. They call this method cell aesthetic. It's all with cell culture, and this is the most important point. Not just take out and inject, make a cell culture, have your banking so you can go again and not again make a liposuction after 1 year, so you have everything fine in the bank. Peptides and growth factors, you know, there are a lot of companies, one is here, and it is very fast working in the immune system, because the thymus is reducing during the age, and thymic hormones are descending over the years, and to give this thymus hormone is important, and you can use this thymus factors or placenta factors or whatever you use for all these indications, from chronic fatigue to cancer and even skin aging and anti-aging. This is what I used, an example for this treatment. I will speak later better in tomorrow afternoon about this, how I use it. This is a special regime of the German Society of Thymus-therapie, how they use thymus and combinations of thymus. Important is that you get up the immune cells, all the immune cells, before and after with these growth factors. And now something very new, probably you know it, but it's actually very new, is the dried spot technique. You all live probably not directly in Jakarta. Who live in Jakarta? No problem with logistics. But you live in Bali, or you live in Borneo, or whatever. You need to send out blood is difficult. So dry spot technique is very interesting. You can use 1 drop of urine, or 1 drop of saliva for hormones, or 1 drop of blood to measure the whole serum parameters you normally measure. You cannot measure the CBC. That's normal. But CBC is very easy, can be done in every local lab. So what you have to do is you just collect all this here, the urine, collect one, and it's a letter, it's just a small kit you send out with an envelope and it's gone, and you get the results very first. So what they're doing now here is the urine titers, neurostress profile, sleep disorders, food intolerance, melatonin, nitrosative stress, hormones, especially hormones with the dry saliva testing, all hormones where we know, periodontitis, and histamine is very important, as you know. And under investigation is the thyroid hormones right now, but it's coming up at the end of the year. So let me come to conclude this. Remember this wonderful picture. It is not so easy to jump in and come out younger. Would be good. I'm always looking for such a bathroom. But we don't have it, so we have to do a lot of new things, use a lot of new tools. Thank you very much for your attendance.
Are they available in the region, or how are they available, and is it compounded?
Yeah, this German Society for Thymus-therapie is very famous in this region. They go very fast in Asia. And they have, actually, I use this product since, I think, 15 years already. So they work very good, they're pure disappointment. You know? There are a lot of the market, some are always good, Korean are good, so you can use what you want, but at the end of the day, you want your patient fast coming back, and the purity of this product is important. And what is important as well is the density of the peptide, of the growth factors. High density of growth factors or low density of growth factors is what we give.
Thank you for the very interesting lecture. I have a question that it is available as a form of injection, IV injection, or IM, or a technical things.
The peptide, thank you for this question, good as well, because we all talk about non-oral. Oral things are difficult, because they are mostly digested, proteins and peptides. So what we are doing is IM, because IV is difficult. IV, you should not go to the IV with peptides. The molecules are big and you don't know what happened. And we don't know if there is an allergic response to IV directly. It's not so good. What I'm doing actually is I give a small dose of like 1 drop, 0.1 milliliter, subcutaneous, which always gives a redness, always. And then I wait about 1 hour. And then if the patient can take this, then I give it IM. And then I start with combinations, and it works. I never had an anaphylactic shock or anything like this. Never. In really interesting years using this.
And then would you do IM injection periodically, or have to do it, how frequent have to inject that?
This is important to you. That's why I develop protocols. And the German Society of Thymus has protocols as well. So I develop protocols for the diseases they have for cancer protection and so on. So for chronic fatigue, we have a clear protocol. For cancer protection, we have a clear protocol. They use the next day or over the next day. So the patients normally, in my practice, they come three times a week for 4 weeks.
Please contact the German Society for Thymus Therapy for further information.